Good afternoon, everybody. Today we are going to continue our neurology lectures, and I'm going to explain today about one of the most important subjects of the curriculum of sixth-year students, which is introduction to or clinical approach to peripheral neuropathy. So to understand this, I'm going to share the PowerPoint presentation. Okay, so to start thinking about what's happening in peripheral neuropathy, first of all, we have to remember to refresh our minds with this simple diagram of the types of nerve fibers that are within our body. So we have motor fibers, sensory fibers, and autonomic fibers. And I want you to remember that motor fibers are always myelinated fibers. So these are A alpha fibers, which is the fastest transmission of the impulses, of neurological impulses. And we have sensory fibers, which are divided into three types of fibers according to myelination, whether they are myelinated, they are thinly myelinated, or they are unmyelinated. And then the autonomic fibers, which are either thinly myelinated or unmyelinated. The clinical implication of this is very important, actually, because when we come to the pathogenesis of neuropathy, we will notice that certain diseases like to affect the myelin sheath of the nerve fibers. And when they affect the myelin sheath of the nerve fibers, they will predominantly produce what's called motor neuropathy. But other diseases don't seem to like to affect the myelinated nerve fibers, and then they affect mainly the sensory, which are unmyelinated or thinly myelinated fibers. And going from there, we will notice that we can divide the neuropathy functionally to either the motor neuropathy. So certain diseases produce only motor neuropathy, predominantly motor neuropathy, or pure motor neuropathy, because these are two different terms. Pure motor neuropathy means that there is no sensory affection whatsoever. But predominantly motor affection, or predominantly motor neuropathy like Guillain-Barré syndrome, we will see that there is an affection mainly of the motor fibers and to some extent the sensory fibers as well. Now, the important thing that even within the sensory fibers, it's not necessarily that we see that there is affection of the whole types of sensation. So we know now that different types of sensation travel along different pathways. And the myelinated fibers the myelinated sensory fibers carry the touch and vibration position sense. And this is the preference of some diseases like P12 deficiency. So they affect the posterior column, and they affect the vibration sense, and they affect the position sense as well. While other diseases, mainly the toxic neuropathies, which are produced by certain toxins, chemotherapeutics of the cancer, and so on, these are going to manifest as sensory neuropathy. Now, moving on to what we call the what are the components of peripheral? Now, why I show you this diagram, which seems to flash back on the histology and anatomy, which you have studied some years ago. But the message I want here to convey is that how complex is the process of homeostasis and maintaining the integrity of the nerves. And if we see this, we can see how many pathophysiologic mechanisms exist regarding how peripheral nerves can be affected by certain diseases. For example, you can see that this is the vasa vasorum and the vasa nervosum. So the vasa nervosum accompany the nerve and supply the peripheral nerve. These are tiny, small vessels, but sometimes they are hit by certain diseases like vasculitis, like ischemia and infarction, and this is going to produce kind of neuropathy. On the other hand, we can see that other diseases can produce the effect on the nerves through the possession of certain materials like the amyloid material. So amyloidosis will produce neuropathy through a completely different mechanism than vasculitis. And now we can explain this through this diagram. There are other pathophysiologic mechanisms that are not shown here in this diagram. So for example, how the diabetic neuropathy happens, it happens through different pathophysiologic mechanisms. One of them is vasculitis, and one of them is direct toxicity to the neurons by the sorbitol and the advanced glycation end products and other toxic substances that produced through through diabetes toxicity. Now, it's very important to know what is the topography of the peripheral neuropathy. So we have what we call the mononeuropathy, and this is the case when just one nerve is affected. And the best example to explain what is mononeuropathy is carpal tunnel syndrome. So people with carpal tunnel syndrome have an entrapment of the median nerve, and the entrapment of the median nerve at the wrist, just inside the carpal tunnel. And this happens due to a variety of causes. So for example, in hypothyroidism, this usually happens. In people on dialysis, due to the possession of certain material here. And this targets or hits specifically a very specific nerve, which is the median nerve. And how this is going to manifest? So it's going to manifest as we go through. We are going to explain this fully. But 3.5 fingers, thumb, and 3.5 fingers and thumb, and half of the small finger, these are going to be affected by numbness. But usually, patients don't come and say that I have 3.5 fingers that are numb, or I don't feel my 3.5 fingers. They usually more manifest with numbness of the whole hand. So here, we will notice that there is this is a very specific condition that is affecting a single nerve. Likely is peroneal nerve entrapment. So peroneal nerve entrapment can happen in certain situations. For example, if there is a compression of the legs for a long time, the crossed leg position, for example, and very long flights, this has been noticed. And here we can notice that only one nerve is affected. Other diseases can cause this, like pregnancy, thyroid disorders, and occupation. And maybe due to hereditary disorder, there is a liability to pressure palsy. So now we know that in all these circumstances, there is just one nerve that is affected. And this nerve is either the median nerve, sometimes the ulnar nerve, sometimes the common peroneal nerve, and so on. Now, there is another term that is called mononeuropathy multiplex. And this mononeuropathy multiplex is more than one nerve. So we have mononeuropathy, we have mononeuropathy multiplex, and we have polyneuropathy. But what is the difference between mononeuropathy multiplex and polyneuropathy? So these are two nerves that are not adjacent to each other. So in mononeuropathy multiplex, it's not non-contagious. So it's not adjacent to the same nerve that is affected. For example, we can have median nerve affection in one arm and common peroneal nerve affection, the opposite leg, and so on. So we cannot attribute this to a disease that is contagious like diabetes or like disc prolapse or like something, but this is much more goes with vasculitis. And I want you to remember that specifically polyarthritis nodosa can produce this. So polyarthritis nodosa is one of the diseases that affect the vessels, causing a vasculitis, and this vasculitis can manifest in neurological manifestations in the form of more than one nerve affected, and they are not usually adjacent to each other. Likely is Sherbish-Strauss syndrome, Sjogren's syndrome, and they require urgent diagnosis because if we treat the underlying cause, we are able to release these nerves from the pressure and the permanent damage to them. And also, we have another category which is called polyneuropathy. So polyneuropathy is a general degeneration of nerve that spreads typically towards the center of the body. So, for example, you all know the stocking and glove hypothesia of diabetes, and it starts slowly sweeping up to produce a high stocking and glove. And now we have an entity that's called ganglionopathy. So ganglionopathy, when you hear this term, it's just a very big term and complex term. When you try to think about it, what does the dorsal ganglia do? So the dorsal ganglia usually, they maintain the integrity of the nerve. So if the dorsal root ganglia are affected by certain diseases, like herpes zoster or so on, they are not able to maintain the integrity of the nerve. And if they are not able to maintain the integrity of the nerve, they are going to produce neurological manifestations. And usually this is multifocal sensory nerves symptoms, like herpes zoster. So if you have seen somebody with herpes zoster eruption, this is one of the worst pain ever that somebody can experience, and usually this is due to reactivation of varicella zoster virus, which remains dormant in the ganglia, so it doesn't go away from the body, and it hits the body severely, causing severe pain under certain circumstances when the immunity becomes compromised, when you have lower immunity or in certain conditions where you cannot fight the virus down its root in the ganglia. So it's going to cause some type of severe pain in certain distribution over the skin of the abdomen or thorax and so on. And other immune disorders as well, Sjogren's syndrome, autoimmune hepatitis, and so on. But it's very important to know that nevertheless we are trying to exhaust all our thoughts, resources, and so on to reach a diagnosis and specific etiology to what is the cause of neuropathy. Sometimes it's not possible to find a cause. And idiopathic means that there is no cause yet identified. And this doesn't necessarily mean that there is no specific cause. But to our knowledge, at this point, a certain disease, we don't fully know all the pathophysiologic mechanisms of all diseases and so on. It remains that sensory neuropathy sometimes happen in idiopathic way. This means that some of the patients are not with sensory neuropathy they are coming to complain, oh doctor, my legs and toes are numb, and then I'm starting to have severe type of pain and so on. And then when you try to find the cause, there is no diabetes, there is no thyroid, they haven't taken any chemotherapeutic, they haven't taken any medication, and you say, oh, now I'm completely blocked, there is no reason that I can think of. And this is the case where it's usually idiopathic. So this is a pansensory affection. Now moving to the next slide. So what these patients usually present with. So people with peripheral neuropathy can present with symptoms that compromise the motor function, the sensory function, the autonomic function, or traffic changes. And as you can see here, these are all peripheral nerve functions. So it's away from the central nervous system. And I will exclude from these the cranial nerves from 3 to 12 because these are 3 to 12 are peripheral nerves. They are myelinated with Schwann cells and they behave like peripheral nerves. And so the motor symptoms, remember that motor symptoms can be either positive symptoms or negative symptoms, sensory symptoms, autonomic symptoms, or trophic symptoms. So here we haven't got the central nervous symptoms like confusion and so on. So the motor symptoms, the sensory symptoms that usually patients present with are either vibration proprioception, diminished sensation, and this usually due to, for example, B12 deficiency. So patients might come specifically complaining of vibration and proprioception affection, and together with hyporeflexia and sensory ataxia. And these, if there is loss of function, so we have divided previously the sensory fibers into large fibers and small fibers. And the large fibers are those which transmit the vibration and proprioception. And if they are lost, it leads to loss of vibration proprioception, and together with sensory ataxia, where people can't know the position of their body in the space. But if they are disordered, this can lead to paresthesia. And the small sensory fibers, so the small sensory fibers can produce pain, diminished pain and temperature, and if there is diathesia or allodynia. Allodynia means that there is excess sensitivity to certain non-noxious stimuli. So certain stimuli that are not painful to us become very painful to these patients who have allodynia. What about the motor symptoms? So we as you notice here, we have not divided the motor fibers into large and small fibers because motor fibers are all large fibers. And if there is a motor neuropathy, remember that the motor neuropathy is a lower motor nerve lesion. So this is a lower motor neuron lesion. And lower motor neuron lesion comes with hyporeflexia, hypotonia. So we have two important components, hyporeflexia, hypotonia, together with weakness and wasting, if this is a long-standing thing. And I will show you in a minute what do I mean by wasting. If there is disturbed function of these large fibers, this can produce twitches of the muscle or fasciculations and cramps. So this is how motor neuropathy presents. And we have all the time to bear in mind that one of the most important causes of motor neuropathy is Guillain-Barré syndrome. So Guillain-Barré syndrome, typically patient comes with 2 to 3 or 2 to 4 weeks of diarrheal illness or viral-like illness, and then starts to develop this type of weakness that starts from the toes and sweeps up to involve the respiratory muscles and then the cranial nerves. And one of the most important cranial nerves involved in this context is the facial nerve. So facial nerve is often affected in those people, and you will always see that the Guillain-Barré syndrome have a tendency to affect motor more than sensory nerves. What about the autonomic symptoms? So the autonomic symptoms are either sweating, whether sweating can be decreased or increased according to whether there is disturbance of the function or complete loss of the function. So complete loss of the function can lead to decreased sweating, and the disturbed function can lead to increased sweating, which is called hyperhidrosis. And that's why sometimes people with hyperhidrosis are treated by an operation that's called sympathectomy. So intractable excess sweating can be treated. I'm not sure, have you seen somebody who is gymnastic or has excessive sweating in the palms of his soles? Have you heard in the palms or soles? Have you heard about this? And then they're struggling with doing their training, and they're not achieving the milestones and the landmarks in their sportish career because of this very annoying problem. And sometimes they go to see the doctors, they offer them the choice of doing sympathectomy. So, and the other autonomic symptoms are various autonomic symptoms like urinary retention, impotence, vascular color changes, and GI complaints. So we have clinical features that are specific to the sensory symptoms like paresthesia, dyskinesia, hypothesia, allodynia, and as we said, that allodynia is pain that is triggered by non-nauseous stimuli. And the motor fibers will be distal weakness. And the distal weakness usually, why it is distal? Because it affects the long nerves and it's length dependent. So the lengthy nerves are going to suffer more, and you're going to see this in the distal. The weakness is more towards the distal, and this unlike the, for example, the myopathy. So in myopathy, you will notice that this weakness is proximal. Okay, and autonomic symptoms are like orthostasis. So they have postural, they drop their blood pressure when they stand up, and this is called orthostasis. And there might be impotence in males, there might be gastroparesis, skin and hair changes, and so on. So sensory signs. So the clinical feature of the signs, we will see that there is distal loss of pain and temperature, distal loss of vibration and proprioception, and not necessarily at the same time. You will notice that both of these, all of the sensations are gone, but some of the diseases will have the preference of producing the pain, taking away the pain and temperature, or hitting the vibration proprioception according to whether they affect the large or small sensory fibers. Motor, they produce distal weakness, more of the extensors, more than the flexors, and there will be distal loss of the reflexes, which are the ankle. Now you see here what I mean by this wasting. As you see, this man has a wasting here, which manifests as a hole here because of the long-standing carpal tunnel syndrome, and then this can produce this picture. And this is another image of what it is like to have wasting in the legs. As you can see here, some of the muscle bulk is gone. So what about the distribution of neuropathy? So as we said before, the distribution of neuropathy can be either symmetrical, generalized polyneuropathy. So this is the most common presentation of polyneuropathy. So usually if it is a polyneuropathy, and this is not mononeuritis multiplex, or this is not a compression neuropathy, we are going to see it as a symmetrical generalized polyneuropathy. And the best example to explain this is stocking glove hypothesis. As we said before in the diagram, please remember that there are different complex mechanisms of reducing different types of neuropathies. We're going to go through and see how each of the types of neuropathy can specifically hit the nerve in a very specific pathogenic mechanism. Multifocal neuropathy means that they are like the multineuritis multiplex of the vasculitis caused by the vasculitis. So they have selection to certain nerves, and you can't say that these nerves are contagious or adjacent to each other. And this is where you will suspect that something is going wrong with the vessel, very small and tiny minute vessels, and this is caused by vasculitis. And usually this is asymmetrical. The focal neuropathy or compression neuropathy, as we said before, the carpal tunnel syndrome, so it's very specific to certain nerves, and this is what's called the conduction block. Diabetes is one of the most important causes of sensory neuropathy. Actually, it can be either sensory or motor, so it's a mixed type of neuropathy. But usually, what happens in most people with diabetes is sensory neuropathy. So it happens in a large percentage of patients. Some people with poorly controlled diabetes, which their diabetes is really bad, they are they start complaining of some muscle affection and motor neuropathy as well. But basically, in diabetes, we have this sensory neuropathy. One of the mechanisms, as we have said before, the endoneural arteriole starts to have hyalinization and there is narrowing of these arterioles. So there is thickening and narrowing, and this is what's called diabetic microangiopathy, one of the most important pathogenic mechanisms. I'm sure that you have heard about or you are aware of other mechanisms that the intracellular hyperglycemia can produce sorbitol, fructose, and sorbitol increases the cell osmolality, and this will increase the water influx into the cell, causing osmotic damage to the axons and Schwann cells, and here starts the process of neuropathy. So diabetes, 70% of patients actually with type 1 or type 2 diabetes will have this type of neuropathy. Can you see how many patients is a very large percentage of patients? So many different types, stocking glove, most common, and the other types, the most commonly involved, the stocking and the glove, the most commonly involved, and you will see that for these patients, we do the hemoglobin A1C. So hemoglobin A1C, which is the glycosylated hemoglobin, or the glycated hemoglobin, is a marker of the long-standing control of the diabetes. So if this hemoglobin A1C is off levels, or if it is out of the range, we can say that this patient diabetes is not under control, and usually these patients manifest with really bad neuropathy. Other important causes of neuropathies are the nutritional and alcoholic neuropathies. And in the Western world, there is chronic alcoholism, chronic use of the alcohol, and then with time, over 30 years, 25 years, 30 years, and so on, they start to develop the symmetrical sensory motor neuropathy, and this is of the stocking and the stocking glove pattern. And some of them, sometimes it's really severe. So in 25%, severe burning pain is the initial presentation, small fibers, and usually what I can tell this patient, so I can tell him that you are drinking too much, you have to cut off the drinking, and then he asks me if this is going to be reversible. I tell him that this is partially reversible because there is some damage to the nerves that is not going to reverse. And as we go through that, we can see that some of the causes of peripheral neuropathy are actually reversible when stopping the offending causes, the offending medication, like those caused by the chemotherapeutics. On the other hand, we will notice that some of the neuropathies will remain even after stopping the offending medication, the offending drug. So alcoholism is one of the important causes, and here we have two B's. So B12 deficiency, but B6 toxicity. So remember that B12 deficiency can cause neuropathy through affecting the large myelinated fibers of the posterior column and the fibers, those that carry the touch and proprioception and vibration sense. B12 deficiency can cause what's called subacute combined degeneration, a very important topic, and it's often very important to put this in the back of your mind, because the leveling here of B12, of the neurological lesion and B12 deficiency, can be difficult and requires experience. And usually it has more than one component. So it takes the posterior column. So B12 deficiency can produce posterior column affection and can produce peripheral nerve affection. And this is usually the large fibers which carry the vibration proprioception signals. And B6 toxicity, on the other hand, so you will be surprised how many people, how people take too much vitamins on regular basis. So I know some people going to gym are just advised by their coach in gym that you have to take these vitamin B complexes so you get more able to train longer hours there and weight and lift more weights and so on. And this is actually a very dangerous practice because as we can see here that excess vitamins can cause damage to the nerve. And so vitamin B6 toxicity can cause sensory neuropathy and gait ataxia as well. So remember please that B12 deficiency, B6 toxicity. Other important category of the neuropathies are the metabolic and endocrine neuropathy. So as you can see that people with hypothyroidism, hypothyroid neuropathy, and these usually have the form of sensory motor peripheral neuropathy and may be presenting with carpal tunnel syndrome. This might be the initial presentation of them. So they might start to have this tingling and numbness in the fingers, and then they have, when we do the test or the electromyography nerve conduction study, it's an axonal type, so it is not the myelin sheath this time. And together you will see some stigmata or some other markers towards the thyroid disease itself, like hair loss, like muscle aches, dry skin, constipation, fatigue, and cold intolerance. You do the blood test, you'll find that there is a high TSH level and the low T4 level. And then there is hyperthyroid neuropathy. So this is a type 1. So in hyperthyroid neuropathy, you'll find it's not a sensory neuropathy. In hyperthyroid or thyrotoxicosis, you'll find that there is a subacute weakness, and loss of reflexes, and this is a form of motor neuropathy. In end-stage renal disease and liver disease as well, you will find neuropathy, but it's controversial whether in end-stage renal disease the neuropathy is caused by the uremic toxins themselves, or they are caused by the original errors that cause the end-stage renal disease, like diabetes and so on. But we know that certain types of neuropathies happen, like carpal tunnel syndrome happen with long-standing diabetes due to the deposition of the beta-2 microglobulin, which is an amyloid material in the carpal tunnel. And usually those patients require transplantation. This comes with a very long duration, very long advantage of dialysis, and then they require that you start thinking about transplantation to relieve this problem. Now here we see a patient. This is a lady with thyrotoxicosis. So as you can see, the salient feature here is that there is a proptosis, and you can see here that there's a thyroid swelling. And now we come to, after the endocrine and the endocrine causes, we come to toxic neuropathies, which is caused by mainly the chemotherapeutic agents. And the chemotherapeutic agents, there are too many, so we don't have to know all of them. It's just important to memorize one or two of the most important. So vincristine is one of them. And vincristine is very important because it produces a kind of a stocking glove tingling. So after patients starting the vincristine, they start to complain about this tingling sensation and stocking and the glove tingling sensation, then profound distal weakness and food drop. So it comes with mainly sensory affection. And symptoms may briefly worsen even after discontinuation. So after discontinuation of this, you may find that there is a worsening. One of the most other important thing or chemotherapeutic agents that can cause this peripheral neuropathy is cisplatin. So cisplatin can cause a kind of neuropathy and can cause lancinating pains, especially common if combined with other chemotherapeutic agents. And one of the very important things in antituberculous, so the INH, and you will, so the isoniazide, please always remember the isoniazide should be taken with vitamin B6, because if it's not taken with vitamin B6, which is 25 to 50 milligram per day of pyridoxine, can prevent this. But if you And if you are not taking vitamin B6 with INH, then you will end up with having this sort of peripheral neuropathy. So we come here to the environmental toxins which can cause neuropathy, and often they are missed because you start thinking about all the time the endocrinological causes, the other causes, and blah blah blah, and then what are the medications you are taking, and you don't remember or don't bear in mind that this patient might be exposed to a heavy load of lead because of health, for example, because of the lead miners and the automobile factory workers and so on. So all these people, the battery manufacturing. So all these jobs and all these occupations are very high risk of exposure to lead. And then after many years of lead exposure, they might come with weakness. And this is because lead neuropathy is predominantly motor neuropathy. Okay, so lead is an important cause. And usually in adults that can produce encephalopathy, GI symptoms like abdominal pain, constipation, weight loss, anemia, fatigue. And this anemia is called sideroblastic anemia, and then it can cause fatigue, and it can cause renal dysfunction. So lead toxicity can be really serious. You just have to think about it. So think that it is one of the important causes of neuropathy. And usually in lead toxicity, there is more than sensory affection of the peripheral nerve, and the diagnosis is through the elevated urinary and blood level of lead. The treatment of this is to avoid exposure to lead and to give them something that's going to chelate this lead from and clear it from the body. So this is called penicillamine, and this will lead to lead excretion. So include lead excretion from the body, and this is what we actually aim for. And one of the most important environmental risks as well to the nerves is arsenic. So arsenic is can be ingested either homicidal or suicidal, or occupational, or contaminated well water. So here we have people who live and depend on the underground water and well water for drinking and for the personal uses of this water. Now the problem that sometimes this water is heavily contaminated with heavy metals, and one of the very important heavy metals is arsenic. So acute high dose exposure can cause Guillain-Barré-like syndrome. So it's just like Guillain-Barré syndrome, but what distinguishes it from Guillain-Barré syndrome is that those people with arsenic toxicity will have motor areflexia, motor affection, areflexia, and it might go into respiratory failure, just like the Guillain-Barré syndrome. But again, this will coincide with severe gastrointestinal GI symptoms, where there is high dose of exposure. There will be abdominal pain, vomiting, and diarrhea. So people with Guillain-Barré syndrome don't usually have this kind of severe GI symptoms, but they here in arsenic toxicity, it will be motor neuropathy resembling this of the Guillain-Barré syndrome, but more with gastrointestinal symptoms. Here we start to think about arsenic. It's quite very difficult still to consider it, but if you take proper history and you start with something in the history points towards that this patient lives in a certain area and similar cases have occurred before, we start thinking about arsenic. And here is how arsenic manifests in clinical practice. You know that nails can tell a lot about the diseases. So nails, a lot of diseases can be diagnosed like chondromalacia, Hafnius sign, and so on, and paronychia, and so on. So exposure to lower levels of arsenic over a long period of time produces what's called Mees line. As you can see, these are white lines. These are white lines that are in the nails when there is hyperpigmentation of the skin, alopecia, and irritation of the mucous membrane. And usually this comes with sensory peripheral neuropathy as well. Now, neuropathy is associated with the vasculitis and connective tissue disorders. We know that vasculitis is the most common cause of connective tissue disease, polyneuropathy. And this is usually happens due to ischemia, infarction of the vasa nervosa. And and again, as you say, it's not symmetrical, so it's not necessarily the median nerve affecting the right side, so the median affecting the left side, but it is asymmetrical and can take different nerves, which is what's called mononeuritis multiple. So the key to thinking about vasculitis is that this nerve affection is patchy, it's not contagious, they're not adjacent to each other, and other things that there are other accompanying manifestations. Now we come to a very important cause of neuropathy, and this is Guillain-Barré syndrome. This is the most common cause of acute flaccid paralysis in the United States. So this is a form of motor neuropathy, predominantly motor neuropathy. So this is a motor neuropathy more than sensory neuropathy. It's an immune-mediated, and two-thirds will have a preceding illness, typically viral illness, before the start of the disease. But it happens usually over a matter of weeks, because remembering that this is a demyelinating form, that is an acute form, because there is a chronic demyelinating form, chronic inflammatory demyelinating polyneuropathy, that resembles acute inflammatory demyelinating polyneuropathy, but has been stretched or spread over years. So one of the most important keys to the diagnosis of Guillain-Barré syndrome is that all of the process has been going over just a few weeks. And one of the very important pathogenic mechanisms is Campylobacter jejuni, and there are antibodies directed against the infection, but they start, instead of attacking this organism, they attack the peripheral and perineum and myelin sheath. And this is why this is how they start causing this demyelinating illness. So the other name for Guillain-Barré syndrome is acute inflammatory demyelinating polyradicular neuropathy. So please remember, this is a very impressive name. So polyneuropathy or polyradicular neuropathy that is demyelinating, and it is due to inflammatory reaction, and this is an acute onset so it's an acute AIDP, because there is CIDP as well, which is chronic inflammatory demyelinating polyneuropathy, which is recurrence of Guillain-Barré syndrome. And here we have sensory symptoms, so it's a predominantly motor, and it's not purely motor. So you have a predominantly motor neuropathy, So in 60 to 70% of cases, you will encounter sensory manifestation, paresthesia, distal paresthesia, primarily motor neuropathy, and pain is very common, and large myelinated fibers, usually vibration proprioception affected, but 98%. So can you see here the discrepancy? So almost all patients will have this motor neuropathy. So 89% will have motor, 60 to 70% of them will have sensory neuropathy. And this will be in the form of ascending paralysis. Eventually the patient will progress to complete paralysis, usually over than 3 weeks. Now there's something that's not completely understood, but it's the seventh cranial nerve is frequently involved, and you might find bilateral facial weakness is common in Guillain-Barré syndrome in about 50% of cases. And the reason for this is that it's a demyelinating disease, so there is no, and it's a symmetrical disease, so there is no reason why it affects the right facial nerve more than the left, or vice versa. It affects both cranial nerves, and this is one of the causes. So Guillain-Barré syndrome is one of the important causes of bilateral facial palsy. Respiratory failure, this is the most grave complication of the Guillain-Barré syndrome. This is the most concerning and life-threatening result of Guillain-Barré syndrome. Almost 25% of patients with Guillain-Barré syndrome require ventilatory assistance. But although they go into ventilator, they can remain on ventilator for weeks, their prognosis is good, because mortality, as we're going to explain, is only 3 to 5% of cases with Guillain-Barré syndrome are going to die from the illness. So most commonly occurs within 1 or 2 weeks from the onset of symptoms. So this is a 1 to 2 week interval. reflexes are lost, as remember that this is a kind of lower motor neuron lesion. And here we can see that there are loss of reflexes or diminished in virtually all patients with Guillain-Barré syndrome because it's a predominantly motor neuropathy. And usually it takes an autonomic affection, so the autonomic system is hit by this disease as well. So if a patient with Guillain-Barré syndrome is sick enough to be admitted to the ICU, he will have this form of autonomic neuropathy. To diagnose it, we have to take some sample from the cerebrospinal fluid, and we will find a very characteristic and preliminary cytological dissociation. So we'll find very high albumin or protein in CSF and not too much cell in the CSF. We do the electromyogram, which is tracing of the muscles, to confirm the clinical diagnosis, and we will find that there is non-uniform asymmetrical demyelination with conduction block due to focal demyelination. To treat it, you have to admit them to the hospital. The peak time to respiratory failure is from 1 to 2 weeks from the onset of symptoms to monitor for the respiratory muscles and autonomic dysfunction. They might sometimes benefit from plasma exchange and intravenous immunoglobulin. The reason for this is that when you do the plasma exchange, you take out the antibodies and you start to give time for the body to recover or the nerves to recover. They're both highly effective treatment for Guillain-Barré syndrome. So the good news is that prognosis is good because 3 to 5% only of those patients die, 70% of patients recover, but only 15% recover completely with no residual symptoms or signs. So there is a good proportion of patients that are going to have, in 10 to 25% of patients, there will be disabling weakness in 10 to 15 to 25% of cases. And patients may recover to a significant degree despite prolonged time on the ventilator. Okay, now to conclude, so we have a variant of the acute inflammatory demyelinating polyneuropathy, which is Miller-Fisher variant. In this, you will find a triad. So you will find a motor neuropathy that's symmetrical, that's ascending, maybe ending in respiratory failure, but you'll find an acute ophthalmoplegia, ataxia, areflexia. And this has the same time frame as Guillain-Barré syndrome. There is an antibody that it's very good to know, but it's not a practical thing to do because it takes usually several weeks to come back, and only very specific, very highly specific labs that do this blood test, which is the anti-C1, anti-C, anti-GQ1B antibody, very specific and sensitive, but usually you will request them, you will wait for weeks, and during these weeks, waiting for them, you have to support your patient, as you said before, that they might be on respirators or ventilators for a very long time, but then they can do it. All right, so for here, we have to break here, and then we will continue the next week. And thank you very much.